Hi, I'm Dr. Choll Kim, and I'm a spine surgeon specializing in minimally invasive spine surgery from San Diego, California. First, I'd like to go over my disclosures. The Spine Sexual Medicine Program is a collaboration between myself together with Dr. Irwin Goldstein, who generally does not need an introduction, but as you know, he's a urologist and a sexual medicine expert, together with Dr. Barry Komisarek, who is a neuroscientist from Rutgers University, as well as Sue Goldstein, who kind of manages all of us and makes sure that the program stays on track. Every 2 weeks or so, we get together and we have a conference where we review all the patients and all their imaging studies. Dr. Komisarek joins us virtually. Fine. And then my job is to determine whether or not there is a surgically treatable lesion and whether or not that surgery is reasonable. There are a lot of patients that have things like disc protrusions, annular tears, and Tarlof cysts, all of which, if they are contributing to their sexual dysfunction, are readily treatable using minimally invasive techniques. And our kind of experience since 2015 are as follows. To date, we've evaluated roughly 900 patients, of which roughly a little over 300 have some kind of abnormality which seems like it's surgically treatable with a reasonably minimally invasive surgery. And for those patients, we've recommended targeted diagnostic injections, provide some additional confirmation that their abnormalities seen on imaging studies correlate with their actual symptoms. But from that whole group of patients, we've to date have performed 70 surgeries of some type or another. And these are the results of the whole kind of mishmash group of 70 patients that we've taken care of. And 67% got some degree of improvement, either very much better, or a little better. If you want to be a little bit more stringent and ask how many are very much better or much better, that's still 42% of patients. And these are patients that have had multiple other treatments in the past. Within this group, I want to talk about a subset of patients. So I want to start out with a group of patients that have PGAD treated by the most minimally invasive surgery that I know how to do, the laser endoscopic spine surgery. That's a little poke hole, endoscopic Band-Aid surgery. Patients go home the same day. All patients have at least 1 year follow-up and up to 37 months. The average is 16 months. And if we use this PGII again, so if you look at that, that boils down to a success rate of 80% if you just take anybody that's better. If you want to be a little bit more stringent and just ask patients that just have 1 or 2s, that's still 65%. And we noticed that if you have a positive diagnostic response, the likelihood that you'll get better is much better than if you have a negative diagnostic response. So I also want to talk about the patients with Tarlof cysts, because that's how all this got started. And using the same kind of scales, 86% got some better. And if you want to be really specific and just ask for patients that have very much better or much better, that's still 57%. So although we're not finding a lot of Tarlof cyst patients with PGAD, when we do, the results of surgery have been excellent as long as they get a good diagnostic response. So in summary, it is clear now that some spinal abnormalities can cause sexual disorders, including genital pelvic dysesthesias. And the pathophysiology is obviously multifactorial because sexual function is very complex. And so using a collaborative format to assess these patients is critical, at least for a spine surgeon. And we've really relied on the diagnostic injections because they predict the best surgical results. And we're constantly trying to find ways to improve our diagnostic capabilities. And we've also noticed that the abnormalities don't have to be huge to cause big problems. Even subtle, small abnormalities can cause big problems when it comes to sexual medicine. And that's important because things like annular tears, small disc protrusions, and relatively small Tarlof cysts, most spine surgeons still think that they are incidental findings and should not be causing symptoms. But in a small proportion of patients, that is not true. It's our job to figure out what patients have a small abnormality causing these sexual symptoms, and we just have to pay attention to those. With that, I'd like to say thank you to all of you for listening, and of course our patients who have been taking this journey with us.